questions.
I was really shocked by the fact that when you said you taught Kant and Mill, that I did not hear Aristotle's name.
All right, I did, in fact.
Okay.
But you can only do so much. But I did teach natural law in a very sketchy way. And being in a Catholic hospital, I also taught primarily from a Catholic perspective and using the ethical and religious directives, which, as you know, rely a great deal on natural law. So the concept of the human person is very key to that in the brief paragraph I read from the Pope, and that's the worldview that is really present. I don't know if I could be an ethics consult in a secular hospital. I don't know if I would know how to do that.
Yeah. Well, you know, the reason I bring up Aristotle is because I suspect that if the issue here is how to approach bioethics from a post-critical perspective, what would a post-critical perspective bring? It certainly seems obvious that Kant and Mill would work against that.
That's correct.
And in fact, Aristotle, who gives us some sense of the priority of the particular situation, would be a better starting point. But I would take it that to bring a post-critical perspective to these issues is just to be aware of the nuances and so on. J.L. Austin used to say that the biggest gripe he had with philosophy is that they oversimplify things. And
That's certainly not been the case this weekend.
If you're going to be post-critical, you're not going to and that's what Kant does.
Yes, absolutely.
That's what Mill does. They oversimplify and give you a formula for doing
exactly.
it. And if things are more complicated than that, that's what I guess a post-critical perspective can bring.
That is one good thing that a post-critical perspective. I don't know. I think it's maybe we have to walk before we can run. And I think it's good for people to understand that floating around in the culture, maybe in their own thinking, besides just simply relativism, Kant and Hume are there. But in actual practice, and that's what other types of theorists have looked at. For example, these, narrative ethics is one key contribution, as well as the person in their body, the person who is dwelling in a sick or who has a disease within their own body, and to recognize that that contribution to it is also very important.
Why do you say you couldn't function in a secular context?
I really don't know what I would refer to. I suppose I would refer primarily to autonomy as a principle. Possibly, I'd still be very tempted to use proportionality, even though it comes from Catholic thought. I think it's a very good rubric to use. But I try to imagine, are things more wide open and less understandable, less limited, perhaps, in a secular hospital.
Would you refer to rules in the Catholic? That's that what you have to bank on there?
It's not really rules. It's not rules. There are some rules. There are 2 or 3 very strict rules, and you can, I'm sure, identify what they are. Direct abortion, and other reproductive things. But for the most part, the ethical and religious directives are things to think about in light of Catholic teaching. So they're not hard and fast rules, but they are guidance in terms of what a person is, what the ultimate purpose of life is, respect for the person. There's a whole section as well on the mission of Catholic hospitals.
And that's what would be missing in the
Yes. Yeah.
Can you explain proportionality? What that means?
Proportionality is what I said with the Pope's statement. It's a we should be able to take reasonable measures, balance the benefits and burdens, And they should always be attuned to what the patient's goals are, not what some abstract,
Right.
yeah.
Sorry. Did you finish your?
Yeah,
Okay,
yeah.
please, go ahead.
Well, I was just wondering whether, I mean, I'm struck by the actual formulation. What would post-critical
Yeah,
perspective
help us
bring? And I'm not sure this is anything to do with a post-critical perspective, but it might have to do with your understanding of the ethicist's role as improving conversation in which all voices can be heard, which it seems to me did not happen in this case.
Correct.
You know,
I would agree with you.
So, but there are such things as moral wounds, and there are such things. I did some work with Lutheran chaplains coming back from the wars, and that notion of moral wounds was very useful in that case, and I think might be very useful here. But there's also a lot of work done on moral ambiguity and the difficulty that people have in morally ambiguous situations, because there's supposed to be a right answer.
Exactly.
You know, we're supposed to know what to do, and so at least if we draw on Poteat more than, say, Polanyi as our post-critical, he was a lot about ambiguity.
He was, definitely.
And so in this situation, if just we focus on the nurses, if somebody had been able to sit down with them and say, you know, you are in a situation of extreme moral ambiguity, this is making you extremely uncomfortable, but that doesn't mean that anybody can solve it.
Right.
I wonder if that would have
Yes.
done some good.
I think that would have been good, and oftentimes we would use a debriefing, I think we would call it, after the fact to talk about especially difficult cases, and it would have been a good idea here.
So accepting the ambiguity is what you're getting at through that conversation.
Yeah, and
That
just
could
saying
have
that
been-
doesn't mean
could have been
that somebody
freeing.
made a mistake.
No.
It doesn't mean
No.
that somebody needs to find the answer.
Do you think in your position you were perceived as a moral expert?
I would come on a unit and they would say, uh-oh, here she comes. Somebody, you know, angel of, I hate to make another joke to you, but angel of death or whatever. Yes, I think I was considered as a moral authority. People would ask me questions about the ethical and religious directives. That's what this priest was doing. My authority in Catholicism would not always be taken, but yes, they did see me that way. But another piece of the authority is just by virtue of being chair of the ethics committee, being head of the ethics department, there's power perhaps in that role.
Two quick questions. Remind me what the diagnosis was?
COPD, terminal later dependency,
COPD.
chronic obstructive pulmonary disease.
Okay, fair enough. What was my other question? What was the nature of the husband's objection?
He, from what I understand, and again, in error, I did not, or not fully, I did not speak with him directly. I got the sense that he just wasn't willing to give her up.
He needs the psychiatric.
Yes.
Well,
He did,
exactly.
but you can't do that. I mean, we didn't find a way to, you know, the family member, you could suggest that they get psychiatric care, but we couldn't impose it on them, to my knowledge.
But so there's never a team meeting, say, where the husband, the wife, the social worker, you, the physician are all together and you're all talking through what the nature of the condition
Absolutely,
is?
very often.
But nobody were ever asking him how he feels? And
Oh,
then-
absolutely, yeah, that would
But
be
nobody
part
ever
of it.
said why? Why do
You
you?
said it didn't happen.
It did not happen.
usually
Oh, did
happens.
not. It
But
did not.
It usually
Okay.
happens.
It usually happens.
But what if he
Wait, hang on a while.
Well, I was just going to ask if over the years now, the issue of shared communication or you felt in your position that you became better and
Yes.
that the staff and became better at having those conversations
Yes.
and in charting the notes and including them
Yes.
and recognizing. And I also had a question about whether there isn't some now medical way to help people wean off a ventilator that makes them more comfortable until they're, so it's not just flipping a switch.
Right,
Is it?
and this, if the decision had been made, my assumption even back then would have been, you give morphine sulfate, so the person does not perceive so violently that air hunger. But what they were trying to do here was to get her back on her own legs in terms of, but certainly the hospice movement, palliative care, there's a protocol or protocols now for doing that.
So, but in your role, the staff, doctors included, nurses, social workers, did all of that web of communication and care improve
Absolutely.
in how you work together?
Yeah, absolutely.
So,
Yeah, so even though this is a somewhat vulnerable case, there were, as I say, 599 that were successful.
Go ahead.
So I was just thinking about this being so long ago, and
Yeah,
one of the
yeah.
questions is the locus of decision-making question, and the question of the role of the ethics consultation, which is always a morally ambiguous one.
It is.
Intrinsically,
It
because
is.
you can only make recommendations.
That's correct.
Which can be followed or not followed, so that the challenge is really to articulate the principles that will make the decision-making easier.
That's
And
correct.
so often what happens is the consult is called when there's a conflict among the various participants of the team of the shared decision-making process. And so I was thinking over the years, a case in which my mother-in-law was clearly brain dead back in the Karen Quinlan era,
Yes.
when people assumed that you had to have 24-hour two-flat EEGs and advanced directives, and we, in this case, we sort of did have an advanced directive because my mother-in-law, reading about Karen and Quinlan,
Yes.
had written to her daughter and me saying, if I were in this situation, which she was, we had this, which wasn't legally binding, but that hadn't been worked out. So it was problematic for all of us, but in this case, her three daughters and I were in agreement. The physician was hesitant, but he understood that we were in agreement. Now, fast forward maybe 40 years later, and when my brother-in-law died, the situation sort of like this. The nurses said to my sister, the medical staff, the doctors and the nurses, everyone said, there will come a time when we won't be able to support him, and we'll let you know when we get to that point. It was not, we will ask you to make a decision which you might feel
Yes,
guilty about,
that's-
but we're just going to make the decision when we get to that point, and we'll just let you know when that is.
How did that seem to you?
That seemed wonderful. And,
Okay, sure,
And for my
because-
sister as well, because, she knew what was going on. It was pretty obvious he was dying. I mean, that he might have died a day earlier in the local hospital, but he had an expensive helicopter ride to get to the medical center, where perhaps it was easier for them to say, we do this every day, and when we get to this point, you won't have to worry about it, we'll tell you when that is.
And I'm sorry, go
Yeah,
ahead.
so I mean, in that case, you don't have to get involved because that's been worked out. But I think that the thing that's evolved over that time is
Yes.
is the role of the ethics consultant, which is the consultant, which is to facilitate that kind of communication.
That's correct.
And in the early years of bioethics, there was and I'll mention who it was. I mean, it's an important chapter in the history. Robert Veitch wrote an important paper called The Generalization of Expertise.
Yes.
And what he was basically saying is that doctors may have technical training, but they're just technical experts. It's we ethicists that have ethical training. And who doctors think they are to make moral judgments, because you need ethicists to do that, which I argued,
Sure.
and I think a lot of people did, but
John
that's very
McCormick.
wrong-headed about that. But in that era, there was...
Sorry, Veitch was wrong-headed or the doctors were wrong-headed?
The Veitch was wrong-headed.
Okay.
In that era, there tended to be an ethicist who was accorded this role of making the pronouncements. And the post-critical response to that is every human being has to make moral judgments.
That's correct.
You don't defer moral judgments to an ethics expert.
But why then were they deferring it to the medical experts?
Well, I think you were deferring it to the medical experts, and that's where the consultation comes in, that the consultation is, not to say that it's the doctors that don't have the expertise we do, but it's not a matter of ethics expertise. It's a matter of moral judgment in the community.
No, but I mean, when the physicians say, we'll get you to the point when we can no longer support it, that's not a technical to support. That's, we're going to make a moral decision that we're not going to keep him going any longer and we're going to turn it off. So
It's
I mean, they may
both.
disguise it as a
It's
medical
both.
language, but it's the moral decision they've decided they're going to make at some point. And that does seem to me like them being the ethicists, which you just finished saying they don't have the technical expertise. I mean, at least that's how I'm reading
I'm
it.
saying ethics, moral judgments isn't a matter of technical expertise. It's
I
a matter
agree.
of moral judgment.
I agree.
So in the situation, had my sister-in-law said, "Oh no, I can't bear to give him up. Keep him on the respirator as long as it takes," or if you turn off the respirator, I won't get the Social Security check anymore. So we want this to go on and on, or whatever it might be.
Yeah.
Then you say, "Where's Dr. Bernal? We need to talk with her."
Right, and all points very well taken. Conversation,
Yeah.
very often an ethics problem is a problem in communication or an understanding.
Totally.
Yep.
So all the lawsuits are communication, not malpractice.
So I imagine this conversation. I'm the husband,
Oh, okay, great.
okay? I'm talking to you.
Yeah.
And I say, so you recommend that we take her off the ventilator? And you say, yes. And I say, who the hell are you?
Mm-hmm.
And you say, I'm the moral expert.
Yeah.
And I say, she's my wife.
Yeah. Don't think conversations like this have not happened, because they do. And you're raising, it's a very thorny issue about moral expertise and whether there is such a thing as a moral, but we can't go into that. That's a very lengthy history. But the truth of the matter is that the ethics consultant helps further the conversation, helps unpack the situation. And actually, it's not the husband who should make the decision in this case, it's the patient. So she should, and we would have to talk with her separately.
So I hear you saying both the patient should make the decision, but also there's a consensual decision-making of the various people who are invested in this case.
Well, you try for that, but it doesn't always happen, and consensus would not be the end
Would not be
the end goal.
Kieran?
Can an ethics committee then therefore operate without someone with ethical expertise on it?
It can, but it will take a lot of self-study. At this point, I would think that it would be rare for people to try to do that, but certainly in a smaller institution they might. What would be better would be if the ethics committee could at least have consultation from someone who could help educate them, or a philosopher, an ethics philosopher, or one of us. But again, there's a great body of knowledge now in bioethics, and it's difficult to just jump in.
Yes.
So the cases get difficult when there are, and I think the point is well taken in terms of being able to articulate principles around the conflict, so it isn't like you and I disagree,
Yes.
and I'm right and you're wrong.
Right.
It's I favor beneficence, and you favor autonomy.
Yes.
And how do we reconcile that at a level of principle, that both of us sincerely adhere to our principles, but we prioritize different principles? And that conversation then becomes easier to have than I'm a good person and you're a bad person.
Exactly.
But in the specifically Catholic tradition, they'd be thinking about this hospital. It wouldn't be either autonomy or beneficence. It would be thinking through the principle of ordinary versus extraordinary care or treatment. And if it was determined that this would be ordinary treatment, they'd be morally obliged to keep it, but this is a clear example would be considered to be extraordinary, which is therefore really to be discerned about when and if the patient wants to decline it. And it would be completely morally acceptable for the patient to decline it. But it seems that it's not a good idea typically to push this with the patient without trying to come to a consensus to families. I mean, in almost all cases, you're going to delay it, have extended conversation with the families, try to figure out where they're at, and try to bring it all to because the reality is often a medical staff can know the patient is dying. But whether intentional or unintentional, family doesn't get passed on to the family, or they don't get it, or they don't hear it, or they're not ready to hear it. And so often, a lot of the conversation is to kind of let the family existentially catch up to the fact their loved one is really dying, and they need to kind of let them go, and simply delaying death by keeping them on the ventilator, ad infinitum. It's not doing the patient any good, not doing them any good. It's kind of just withholding the grieving and all this kind of stuff, and they are dying, and it's clearly not killing them from Catholic moral teaching with removing the ventilator. It's clear that the
I
pathology
think
is
a
killing
better
them,
way, and what was recommended in EPIC, educating physicians on end-of-life care, is that at the beginning of a life-limiting illness, you're realistic with the family. You discuss with them so that they don't assume that a cure is going to be the goal forever, so that other goals are discussed, and so it's not such a shock or surprise to them.
What if the will of the patient is that they be disconnected?
I'm sorry, what?
What if it's the will of the patient? Please disconnect me.
Yes, okay.
And the family has no clear moral imperative other than that they find it inconceivable that they should pull the switch.
Mm-hmm. The family's completely against it.
Well, yes, there are easy equations in terms of costs that are obvious, but there's the sense that this person is still an intelligence, and there's no way we're going to pull the switch. I'm not even sure what the legal situation would be.
What we would try to do in that situation, a care conference, a very good way to begin is for the doctor to review what the medical facts are. But then in a situation where the family is in disagreement, we would try to refocus on the patient. What would they have wanted? What did they say in similar situations? What were their values and goals? And many times, not always, the family will then gather around that and be more at ease that what they're doing is for the patient. It's the patient's wish, not their own. And they can also reaffirm the personhood of the patient as well in that way.
Friends, can we put a dash in this conversation?
Yeah, I think we've
I
gone
think we're
over.
going over, but we started late, so roughly on schedule, off the schedule. Dick, would you say